After Dr. Maudlin, and then we'll have a break. And everybody else will move up and we'll have the question and answer either in two places or one place this morning. Thank you. And now I'm going to introduce some people on our board, on our task force. Dr. Al Dreger and Dr. Jean-Luc Urbain. And they have something to tell you about June 3rd, when CNETS Canada will be going to Ottawa to Federal Health Committee.
Thank you, Maureen. In today's world, as you know, the socioeconomics and the financial aspect of the world is not very gratifying, and it's a long struggle, particularly for healthcare. Over the past few years, the healthcare provider and patient advocacy group like this one have worked very hard to try to convince the politicians, both at the provincial level and federal level, that rare disease are as important as very common disease, and those patients who carry rare disease need to be taken care of. So I'm really pleased that yesterday Maureen and I got the invitation to testify to the Healthcare Parliamentary Committee in Ottawa on June 3rd. They want to hear about rare disease. We have been discussing, trying to strategize to make sure that we can create in Canada a center of excellence, and that was also the purpose of this meeting, is to try to create a network of competence to make sure that within the next few years, those of you who are suffering from this disease can go to a center of excellence where the expertise is there and you get the best possible treatment. So Maureen and I will represent you on June 3rd, and we'll try to do as well as we can, and we'll debrief you guys through CNET Canada of the outcome of that meeting. Dr. Dreger, thank you. Al Dreger is to me like the father of nuclear medicine. He recruited me in London, and as soon as I came to London, he said, well, now you're in London, I'm past age retirement, so I'm retiring. And I said, no, not so far. I cannot lose the father of nuclear medicine. So I keep him alive and involved into whatever I've been doing over the past 6 years. I'm sure that his wife Liliana is not necessarily very happy with me, so at times I'm trying to avoid her because I'm stealing him from her. But that being said, we've become very good friends, and I was able to get him involved with the neuroendocrine tumor. Actually, he was involved way before I was. I was still probably not born before he got involved, but that's another story. Hal?
Thank you, Jean-Luc. This is going to be very ad hoc because I didn't know I was going to do this when I came into the room. But there are three things that I want to pull together. One is a conversation I had by email with Jim Cormos a few weeks ago. The other is Jean-Luc's talk last night on personalized medicine. And I think, and the third is an article that was in the Globe and Mail yesterday, page 3 of the first section, if you still have it in your room, which was about progression and development of nanorobotics, machines at the molecular level programmed by DNA, if you like. Now, I think it's helpful to see how far we've come in a short time. 20 years ago, there were some people sitting back in their offices saying, wouldn't it be nice if we could only afford to sequence a human genome and determine what the sequence of DNA is? And that eventually got underway. It took 10 years, the world's best labs collaborating. It cost $3 billion to do it once. 6 months ago, there was a lab on the West Coast in California announced that they had done the same analysis in 3 days for a cost of $6,000. And as you saw in Jean-Luc's talk last night, the goal of the research just now is that within about 5 years, we want to have genomic analysis available as a diagnostic tool for $1,000 on an overnight basis. We have to learn to ask the right questions of that before it becomes really useful. But that's how far we came in about 20 years. Now, spinning out of this, about 6 weeks ago, I saw an item in the medical news that there were 6 recognized genes in breast cancer that can vary independently and that have an impact on the outcome of therapy. And the news item had to do with the lack of funding for these tests. Well, last week, and if you stop and think what that means, is that breast cancer is no longer one diagnosis. It's become a matrix of 6 times 6, which is 36 different diseases, depending on and having different outcomes. Last week, there was another study reported saying that investigators had found 18 independent genes that played into the behavior of breast cancer. And at this point, it's no longer 36 diseases, it's 324 diseases, assuming that the genes are just toggle on and off. But they don't just toggle on and off. As you saw, if you saw Jean-Luc's slide last night, there are many things that can happen in one gene that affect its behavior. So that becomes a very high power. And what we realize in the end of the day is that every cancer is as unique to the individual as your fingerprints. And at the moment, we're just brushing by the first edge of personalized medicine, in which we're looking at the behavior or the characteristics of the genome and asking, will certain drugs that we now have available work on this person? The next step we need to imagine, and it might come sooner than we think, given the rate at which we've made progress, and looking at yesterday's Globe and Mail, that we can program molecules to be synthesized very specifically. And I think we will come to a time when the blockbuster drugs won't do it anymore. We'll want to synthesize and be able to synthesize individual drugs for the individual cancers. So every cancer is a rare disease in this situation. Now, what does that mean for how things will look? One thing I fear is that it'll be the end of clinical trials, which depend very largely on grouping together the people who are similar, as identical as we can make them in today's frame of knowledge, and studying them to get the statistics of the responses. And we have to think of new research technologies to cope with the uniqueness of cancer. The second thing I suspect it means is huge upsets in big pharma, who will have to learn how to work with personalized medicine. And the third thing I think it means is that there's going to be a big upset in our regulatory agencies because they don't have the means of dealing with these issues. As you see, they don't have the means at the moment to deal as effectively as we would like with what we call orphan diseases. When every disease is an orphan disease, they have to work very differently. So that's just a little perspective I wanted to share with you, and I hope it's helpful to you.